I'll try and keep it as much as clinical as possible. You can stop in between also if you find it anything difficult to understand. It's customary to have a disclaimer. I do not have any conflict of interest or not work with the alcohol or tobacco industry. This presentation basically for academic purpose. I have the slide as stock for every one of my presentation. I'll have it here also. Isaac Asimov had described your assumptions or your windows on the world. Scrub them off every once in a while, or the light won't come in. Let's try to keep our glasses as empty as possible. My interest in behavioral addiction has started sometime back, but theoretically, my interest started by reading this paper, and I keep quoting in most of my ward discussions and my um, presentations. This is a seminal paper which all of us who have interest in behavioral addiction and research in behavioral addiction, both not only research, even clinical aspect also should read. It's called as Are We Over Pathologizing Everyday Life? And it's not only this, and there are 8 to 9 commentaries which are equal or even bigger than this particular opinion paper, which talked about the nosology, the relevance of different forms of behavioral addiction. It will be wonderful reading. If anybody is interested, you should go and read this. It is still available online free. When we introduce this topic, we need to agree with the fact that still the clinical description are not completely clear. There are a lot of questionable aspects in the clinical description. The available evidence towards both on the assessment management side and on the treatment side is limited and not a big evidence to help us to make decisions. Regularly, people come to us and we need to work with them. So, what do? I'll take this as from not from the theoretical point of view about what is behavioral addiction, when it started and all. I will start from how a patient reached to us in the clinic and what do we do. It is based on the treatment models for the affected individual, and it's in addiction itself. This is the first thing which we think of when somebody come into our chambers, right? One is complete abstinence model, another is harm reduction model. When it comes for complete abstinence, again, the complete abstinence approach will differ on what is the kind of addiction, what is the kind of nature of the behavioral addiction, type of the behavioral addiction, and there are a lot of in behavioral addiction, especially in the gaming addiction, complete abstinence has been propagated as the best treatment in some of the programs, especially in China. This is very common Chinese bootcamp approach. Although these days I'm not hearing much on this program, but still, it is basically on the disciplining nature. The proper digital detox was done in this program. I think this has been running from the 2014, I suppose. Taoran is the person who's in charge of doing this, where they have been put into a bootcamp approach without any kind of digital gadgets with them. And the question which comes to us is it pragmatic? Right, at one point of time, we can all talk about completely making them abstinent from it. It's not like alcohol. It's not like tobacco. Here it is day-to-day living needs gadgets and internet. How do we, what is the pragmatics of not having them at all, right? Sometimes you have to question the morality of the kind of treatment which is being given. What is the ethics of it like, right? If we push them to do this complete abstinence, there will be a therapeutic rupture which happens. We don't get to engage with them on a long-term basis because we are taking a very hardcore approach over here. And even if we push the complete abstinence, what is going to be the long-term outcome? These are questions which usually come into my mind. I said, I'm a clinician, I have biases. So this is my bias in terms of going against complete abstinence model. And that's why I believe in harm reduction model, right? In harm reduction also, there are two kinds. Not every one of us are doing harm reduction proper. Right? Harm reduction was from the start, accepting the fact that you can reduce the usage so that it doesn't harm you. But most of us follow, you initiate harm reduction, gain a therapeutic alliance, and then move on to complete abstinence model. Most often we try to follow this kind of intermediate harm reduction approach rather than the hardcore harm reduction approach. There's another slide which I commonly use in most of my addiction presentation. I believe addiction evolves from the core of vulnerability. Each of the individual who have addiction, right, they seem to have certain amount of vulnerabilities, both biological side and on the environmental side. Biological includes family history and like children of alcoholics and other things, and temperaments in terms of externalizing or internalizing or autistic temperament. And then the environmental vulnerabilities includes the developmental stressors from poverty to parenting issues to whatnot, many other abuses and other aspects which comes in life. Just because the vulnerability is present, they are not going to develop the psychopathology. In between the vulnerability and the psychopathology, there is something called as proximal antecedent, right? These are biopsychosocial events. When they happen to people who have this vulnerability, it manifests, the phenotype of addiction manifests. What are these proximal antecedents? It could be just exposure to cannabis. It could be a break in a relationship at a certain point of time, or school dropout, right? Or some kind of loss of relationship, something happens, right? These are the proximal antecedents. This distal antecedents and proximal antecedents, when they combine together, that lead on to development of the particular psychopathology, which not necessarily addiction all the time. It could be any psychiatric comorbidities, sometimes even physical comorbidities too. Here, our interest is addictive behavior, so we just put there addictive behaviors. And there could be other high-risk behaviors also, not necessarily addiction or mental illness, just high-risk behaviors as such. Now, all these three things could be there along with physical morbidity. These all things together called as multimorbidity. Multimorbidity is the rule than exception at this point of time. And these multimorbidities will result in consequence. And when consequence happens, it could be because of the addiction. It could be because of the other high risk or other comorbid behaviors. But most often it could be a combination of both. Now, this is how I understand the evolution of addiction. And we need to describe our patients with addiction in this format. It gives a very different perspective of looking at addictive disorders per se. Most of you would have heard about all these things in the past 22 lecture series. I'm just summing it up. Now, this is some research which we did on gaming behavior. Gaming is normative, is what some of us believe. And it's not something very esoteric. Gaming is normative. I game. So many of us do game. But how it differs from people who are pathologically gambling, or gaming. So we wanted to look at it. We did qualitative research on this to understand the gaming behavior itself. Like initiation of gaming most often happens many people like, and it has its own rewards in terms of how it is helpful in mood modification, how the kind of contents which is being present over there, how easily you can download and see something. There are social aspects to it, and how you can be immersed when you are distressed about something else. I mean, it happens to most of us. And then somehow, certain point of time, there is increased online gaming do happen. Now, increased online gaming, it's on itself, it doesn't become pathological over here. But when this increased online gaming behavior, when it gets combined with not so protective factors or the risk factors and not enough of protective factors, right, it results in pathological gaming. If the protective factors of more, then it becomes control gaming, and there is no much major consequences happens. Like quite often, when we understand that we are doing more, we delete it and then move on with our activities. We may reinstall or re-download it at certain point of time when we are distressed, but it doesn't continue in the same way. But in pathological gambling, it doesn't happen that way. It continues to be remain pathological, and it causes negative consequences. So the first step in treating these group of people, or just managing even before assessment, is to create a good therapeutic alliance. Now, Jerome Frank, one of the renowned psychotherapists, had talked about therapeutic factors which are helpful, the common factors approach in psychotherapy, which are helpful in any form of therapy. he reported that no, it's not the content which matters. It's that who delivers and how it is being delivered, it matters. Now, when we talk about the therapeutic alliance, there are two parts to it. One is about who delivers and how they deliver. The kind of relationship which we create with our client is very important. And we need to invest on it, both on time and energy. And that will definitely help in them coming back to you and them sticking on to the kind of management aspects we are going to push in. And we will be more successful in that. It is definitely difficult, not any less than a cardiothoracic surgeon's work, right? To get an adolescent to stick on to you, right? It may take multiple sessions also. You may not be able to do it in single session. We really, really need to be actively listening to them without judgment over there. And we need to learn to speak their language also. If we do not know their language or lingo, we really need to learn from them and then equip ourselves for the next session. That's how we can create a therapeutic alliance. And we also need to be control our own urge to correct. The writing reflex need to be corrected over here. We need to wait. And being honest is very important over here. Sometimes we may feed into narcissism. It is not bad. All of us do have narcissistic traits. It is good to feed into the narcissism of a client so that they find good about it and then they stick on to you. And following their lingo is very important. The second factor which Jerome Frank talks about is that it may be the same information like the 100 people had talked about the problem which this person had before he or she reaches to your chamber. But you are going to give it in a different format, right? We need to reframe the problem in such a way that we are nearer to the solution as much as possible. Jerome Frank talks about how you need to add and collect new informations with the same problem, right? And give new meaning to it, right? And take some of the negative and the stigmatous attitude from that problem. This will help them to stick on to your program and the rapport is created. So even though you're not doing anything great, there is the path to solution is as nearer as possible now. So reframing the problem is in them. The step 2 is assessment. 50% of our, or 50 to 60% of our job is about having a good assessment. Right? If we give it to somebody else and then we only look at the management plan, it won't work. We need to do a proper assessment. Right? Without proper assessment, we may not be able to achieve our outcome as such. So it is ABC, as we have discussed, like antecedents of vulnerability. B is the specific addictive behavior, and C is the consequence of comorbidity. Assessment of behavioral addiction, not very different from the other addictions, but we need to focus on these aspects of it. What are the gambling and internet use related pattern, and how the internet or gambling pattern is in an addictive form, right? So that if you are to elicit, you need to ask about the type of it, the nature of this behavior, quantity, frequency, and the current pattern, mode of use, online, offline, right? And factors associated with this would be initiation and maintenance of the pattern. What are the positive expectancy from the behavior? We should not miss out on this because this will determine whether the person will be able to stick on to the management plan at all or not. What are the reasons for abstinence or relapse in the past? What are the reasons for abstinence or seeking abstinence at this point of time, even if it is external? What is the current motivation? And which are the factors which needs immediate intervention? These are certain aspects we need to look at. Now, internet use pattern and the abnormal or addictive pattern, if you could collect information around this, what Griffith has talked about as the components model of addiction, it's be good, where salience is something which we need to look at. Salience is the same as other substance disorder. What kind of mood modification happens over here? Any tolerance has happened, right? Withdrawal symptoms, the conflict, both the internal and external conflict which arise in this person because of this behavior, right? And relapses. Like if you could organize our information related to psychopathology after this type and of quantity, frequency, mode of usage, and all. We need to organize the online gaming and gambling information around this. It would be useful. Primarily, I had focused it on the gaming disorder and DSM-5 and ICD-11. I need not talk about it for want of time. I'll skip this. So this is 5 out of 9 criteria you need to satisfy here. 3 core criteria are being talked about. So we need to focus on this. We should not forget about the non-addictive psychopathologies also, where poor cognitive control, poor emotional control, high rejection sensitivity, loneliness, and high perceived stress, right? Distress intolerance, all these things are a component of the non-addictive psychopathologies in this group. We also need to look at experiential avoidance. Some group of people would want to avoid the realistic space so that they could go into the online space to do whatever there inside to get away from the real life. And there are high-risk behaviors, deliberate self-harm, and the functionality would form the non-addiction related psychopathology. Complications and consequences, yeah, physical, mental health, and social and legal complications. You all are aware of it, how it can happen. Comorbidities includes the psychiatric comorbidity and medical comorbidity. Medical comorbidity, obesity, and NCDs are common in this group, right? Vision deficits, chronic musculoskeletal issues are commonly noted with this group, so we need to be aware of it. Very high comorbidity of ADHD and depression has been noted in behavioral addiction. We need to look at that specifically. And if there is a temporal sequence available, it will be useful to make treatment decisions also. Again, family vulnerabilities need to be assessed. Not necessarily all authoritarian parenting is a problem. These days, authoritarian parenting is seemingly providing a little bit of protectiveness. What is worse is in negligent parenting or ignorant parenting is what is causing the trouble. So that part should be elicited. And other adverse childhood experience can be assessed. Temperament, please give some time in assessing the temperaments. On the internalizing pathway, where the distress is internalized quite often, ranging from low self-esteem, depression, passive-aggressive behaviors, procrastination, poor communication skills, to externalizing behaviors, which includes ADHD, ODD, CD, and ASPD. Emotional instability, high novelty seeking, low harm avoidance are very common in this group. Now, these two are not mutually exclusive, right? It can most often they are present together, and it's not alone. And in this group of disorder, there are also a set of patients who present with autistic phenotypic spectrum. It's not autism, but you find like hitting a wall after a point, we are not able to clearly determine what is the reward for them, how to determine reward for them to work with them. Some of them are aloof, poor social skills, poor emotional recognition, extremely high functioning in certain aspects of their life, and there are stereotypic behaviors noted in that. Again, these are not mutually exclusive. All of them can be present together, and they make it more complicated and complex. Treatment includes enhancing motivation, handling vulnerabilities, treating comorbidities, and focusing on alternative pleasures. Now, when we treat, we should go on the opposite order of the assessments. Consequence need to be treated first, psychopathology next, and then whatever from the vulnerability component we can address, we should address. My take on the management model is this. I equate that to learning ballet. In learning ballet, there are 4 components which are needed. First one is that I should want to learn ballet. Second one is I need that infrastructure. As she's dancing, it cannot be danced anywhere else. Otherwise, her ankle and her knee will be gone. And there's coaching needed. Somebody needs to help me to learn it. And I need to keep practicing. Unless I have all these 4 components, I won't be able to achieve learning ballet. Similar to that, if I want to change something in addiction or in the management model of behavioral addiction, I would look at motivation, working on motivation through psychoeducation and MI platform. To the infrastructure, here it will be mostly medication, where all the comorbidities, all the factors which are making them to resist any form of treatment, we need to address that through medications. And then specific psychosocial interventions on the factors which are causing the addictive behavior needs to be addressed, and then regularly practicing whatever has been done. These 4 components need to be there for us to achieve anything at all. So that's where the combination of pharmacological and psychosocial intervention is essential. Interestingly, when it comes to pharmacological intervention, we do not have much towards this behavior, right? Most often it is treatment of comorbidities. There's no specific medication which has been pushed into this area, except for in pathological gambling. Naltrexone seems to have some better evidence, followed by topiramate and other agents also. Naltrexone has been tried between 150 and 200 milligram in this group. When it comes to psychosocial intervention, MI holds importance even till date. Miller and Rolnick has released the fourth edition also. The assumption is that the person is in ambivalence. And through a collaborative work with the client, we are going to make the client to take up the task of changing the behavior, right? And that has to be evoked from the client, not being thrusted upon the client. That is the core of motivational intervention. And good relapse prevention plan based on what makes a person to go back to it. CBT internet addiction is one thing, and even gambling disorder also is available. CBT internet addiction, Dr. Pravat said that it's being discussed. I think I will not spend much time on this thing. We also work on certain other aspects which make them to go and use the internet or other forms of behavioral addiction. It's because of the experiential avoidance I talked about. It could be procrastination, perfectionism, social anxiety, poor self-esteem, poor distress tolerance skills, and blah blah. Very many other forms of things like say catastrophizing, black and white thinking, body positivity, body shaming aspects, poor interpersonal relationship skills, poor self-compassion. This is not being taught, even to us doctors also. This is not being taught, self-compassion. So all these aspects are going to contribute towards a relapse to any of the addictive behaviors and behavioral addictive behaviors. We need to work on them specifically to get them out of this behavior. Again, when we talk about removing one behavior, we need to understand that there is a vacuum which is being created. So how do we fill that vacuum with something which is useful and which can be followed by the client themselves? So that's where the positive alternative behavior or positive addiction comes in. Encourage your clients to have positive addiction. I can discuss about it later in the discussion. And there are gamblers and gamers anonymous. Family therapy is one very important aspect because they will push you to make changes in the client's behavior immediately, which you don't have, which you have to say, I don't have a magic wand, and we need to work with them significantly. Sometimes the client will not come, so you would want to use whoever is coming as surrogate therapists to manage them. Prevention strategies, there are generic and specific. Generic is for other addictions and even other psychiatric disorders also, which I would say you should read this if you're interested. These are generic strategies for prevention, and these are transdiagnostic in nature, right from perinatal to middle childhood, early adolescence, adolescent and adulthood. There are different things that have been discussed. And there are interventions to develop to handle the developmental stressors. Specifically, I would look at mentoring the high-risk kids. Peer influence is quite great. Instead of dreading it, we should jump in and use it towards the pro-social behavior. I'll not go into the details of it. Again, parenting, there are different aspects of parenting we need to work on. And community intervention. The community should be as conducive to the client as possible so that they can get involved in multiple activities and not only with the rewarding behaviors. Some controversial subjects are always there. I think it varies with parent to parent. When do you introduce sexuality? When do you talk about pornography? When do you talk about recreational drug and gadget usage? When you talk about body image, it varies with different people. We need to have a clarity about this. We need to openly talk about this. We need to encourage them to talk, the kids to talk to us. If we are not doing, then there is a high chance of they getting into some addictive behaviors around these things. So it should be who, where, when, what, and how this to be introduced. Specific strategies. There are healthy way to use gadgets, so that needs to be inculcated from the start. And there are healthy ways to use internet too. I can share this with you guys. And even in gaming also, we should look at those aspects. In summary, reframe the problem focus. Intervention need to be titled for the patient's profile. Involving all stakeholders is important. And there are different models of intervention are available. but it is based on the interest of the clinician and the clinical status of the patient itself. And obviously, we need to have more evidence-based interventions. This is a summary. The dream path is this, but right now we are in this state. We need to. This is our Bangalore roads. Prevention through health promotion for the population at large and developing appropriate treatment models or strategies for the affected is needed. If the road ahead seems daunting, past to remember just how far you have already come. The important thing in science is not so much to obtain new facts as to discover new ways of thinking about them. Thank you.